the mean age of the study population was around 29 plus minus 7 years, and majority of the study population was in the age group of 25 to 34 years. So as we can see that majority of the study population are there in this age group, and in this around 30 were females and 14 were males. So coming to the interpretation of the impact of event scale, which are used to assess the psychological impact, this scale, it divides the overall this thing into 3 subscales. That is the intrusion subscale, avoidance subscale, and hyperarousal subscale. So accordingly, the interpretation of this is, if the mean is 0, then it means that there is no stress at all, and if it is 4, it is higher stress. So in my study, I found that there were no intrusion symptoms, no avoidance symptoms, and no hyperarousal symptoms. And the total scores of all the responses, if it was more than 24, then it is said to be, the person is said to have a high post-traumatic stress disorder. So in my study, I found only few overall symptoms. So it suggests that there was no post-traumatic stress. The themes and codes of the stresses of being quarantined were the codes which are generated due to the time constraint. I won't be able to show all the verbatins. So the codes which were generated were fear of being COVID positive, extreme boredom, frustration, inadequate supplies, being away from your loved ones, and lack of information. When we had asked about the psychological impact, the themes and codes generated were emotional disturbances, anger, depression, low mood, irritability,
Sorry
stigma.
to disturb you, ma'am, but 1 minute is left.
Okay, thank you. Loss of wages, tensions, and insomnia. Here are just some verbatins which I have just mentioned here. So one person said that when I was quarantined for 14 days, I get infected with coronavirus. And during the period of quarantine in the hospital, I feel there was extreme boredom, as we were not allowed to go out anywhere and we had to be within the 4 walls. So these are all the some of the verbatins which I have just mentioned here. Quarantine is one of the most important measures, and spending time in quarantine, it can take a serious mental toll. In the present study, the subjects had no intrusion symptoms, no avoidance symptoms, no hyperarousal symptoms. And in the qualitative part, the people were observed to commonly experience fear of being affected, sadness, insomnia, depressive symptoms, and extreme boredom. These are all my references. Thank you, everyone.
Thank you, Dr. Amrita. It was a good presentation. Just I would like to know about any suicidal tendencies or any other psychological factors, mainly which were there during the time of the quarantine period.
Sir, there are like other studies have found it, but in my study, I didn't find any suicidal this thing. There were some other studies where even suicidal tendencies were seen, because this study was done in the month of April when the lockdown phase was there. So that time it was like it was a lot of stigma also was there, but I didn't find any, sir. I didn't find any suicidal tendencies.
So important is the stressors are actually what you found actually during the study period.
Sir?
Stressors, important stressors, which were there among the.
Yeah, that's what. So people, they were like really scared of being COVID positive, and they were like, that was, I mean, the boredom, frustration, and they were they were missing their loved ones, their family members, and they felt that they didn't get adequate supplies when they were in quarantine, and some of them even reported financial stress because due to the quarantine they had to lose their wages and all. So these were all the stresses which. And also people were, they had, some people, they said that they had insomnia and all because of this.
Actually, some of these were you would have mentioned in the graphical presentation. So
okay, yes,
it was
okay.
good actually. Thank you.
Yeah.
Dr. Amrita, so
Yes,
what
sir.
do you think is the implication of the results that you have I know
Sir,
that I
actually-
saw the conclusion slide, but what do you think is the implication? Because quarantine remains one of the important measures and it has to be there. So what do you think is the implication of the observations and the results that you have?
Sir, actually speaking, when I had done the study, it was like, I think it was more relevant. Nowadays, like, it has become very common, sir. I don't think so. It is so, stressful for the people to be quarantined, because now it is like people have got used to it and all. So when I had done it, yeah, I just wanted to see about all this suicidal tendencies and all, and to rule out what the people would feel when they were quarantined.
Okay.
Thank you, ma'am. Moving on to the next participant. Can I ask Dr. Pradeep to present?
Yes, I'm there. I'm there. I just want to share my screen.
Yes,
Just
sir.
a second, sir. Where is it? Here.
Screen.
Sir, please share your whole screen, not just the window.
Yes, just a minute.
Yes.
So your PPT is visible. Can I start the timer?
Can you see the screen now?
Yes,
Yes,
sir,
sir.
we can see.
Okay, fine.
Then start the timers.
Okay. Good evening, everyone. Today I will be presenting my research titled COVID Anxiety Among Frontline Healthcare Workers in a COVID Care Center. Background. One of the sector which has been working tirelessly since the COVID pandemic has started is the healthcare sector. Frontline healthcare workers are those who come into contact with the cases in a COVID hospital, which poses them to a greater risk of contracting infection. With the growing fear with excessive workload, working hours, inadequate personal protective equipment, over-enthusiastic media news, feeling inadequately supported by family members due to long quarantine days, have added more to the psychological issues of these health workers. Contracting infection among healthcare workers has added more to the feelings of anxiety, helplessness, loneliness, guilt, resultant insomnia, which has been affected their mental health. Frontline healthcare workers are in close interaction with COVID-19 victims, and direct observation of these physical as well as emotional suffering have made them, it is one of the depressing factors and during this journey. Pandemics can lead to a heightened level of stress and anxiety. Stress and anxiety is a common response to all these stressful situations. So with this background, the study was started with the objectives to assess anxiety, work and social adjustment, and stress among frontline healthcare workers in a COVID care center, to assess factors influencing anxiety, work and social adjustment, and stress among frontline healthcare workers in a COVID care center. Methodology, it was a hospital-based study. R.L. Jalapa Medical College Research Center, which was a COVID care center, was a part. It was a cross-sectional study carried out for a period of 3 months from July 2020 to September 2020. Study participants were frontline healthcare workers who were doctors and nurses who were part of treating patients. Sample size was calculated using OpenAP software, using 35.2% as a prevalence, which was around 360. Inclusion criteria, all frontline healthcare workers who had not contracted the infection, frontline healthcare workers working in COVID-related wards, ICU, outpatient department were included in the study. Study participants who had already contracted COVID disease were excluded from the study. Study tools, to assess socio-demographic profile, pre-tested semi-structured question was used. To assess perceived stress, Cohen's perceived stress scale was used. To assess how COVID has affected their ability to carry out day-to-day activities, work and social adjustment scale was used. To assess anxiety, Corona anxiety scale was used, which was developed by Sherman, Lee et al., specific for Corona. Informed consent from frontline healthcare workers were taken. Study was started after IEC clearance. Data were collected by sending the link through WhatsApp group and through the Google Forms. 3 reminder mails were sent a week apart for all frontline healthcare workers who had not responded for the first. Survey took not more than 15 minutes. All data collected were coded and entered in Microsoft Excel, analyzed using SPSS version 22. Chi-square was applied wherever needed for association, and regression analysis was done with statistically significant p-value defined less than 0.05. Around 850 frontline workers were finally shortlisted to work in these COVID care hospital. 95 of them had already contracted infection, so they were excluded from the study. 60 consultants were above 50 years, though they were the part of COVID care's treatment, but they didn't actually meet the patients, so they were excluded. 120 frontline healthcare workers resigned the job once they were forced to put to work here. 60 did not reply even after three visits. That's something like reminder mails. So they were excluded. Finally, 362 participants participated in the study who fitted our inclusion exclusion criteria. Table 1 distribution. This distribution shows around 67.1% were female participants, 57.7 were unmarried, 51.7 had working hours more than 8 hours per day, 52.2 thought that their working load was medium, 73.2 showed that their regular shift was followed, and 64.6 said they could get around 2 hours of resting time between. So this is distribution of study participants according to the place of work. Majority of work in the participants, they worked in COVID wards, and next common was seen in COVID ICUs. Now, distribution of frontline healthcare workers according to their mental health status. This slide shows that 73.2% had moderate stress, and severe psychopathology related to work social adjustment scale was seen in around 49.2%, and corona anxiety was seen in around 54%. So distribution of yes, thank you. So distribution of frontline healthcare workers based on usage. Now this shows around 338 had N95 masks, and around 120 had protective boots. Now coming to the association between perceived stress and various factors, occupation was found to be significant, and other factor was regular working shifts was found to be significant. Association with work social adjustment scale, gender, occupation was found to be significant. Association between corona anxiety and various factors, occupation was found to be significant. Along with that, working hours per day, perceived workload during COVID duties, regular work shifts followed during COVID duties, hours of rest during COVID duties were found to be statistically significant when with chi-square. However, regression analysis showed no statistical significance, however, higher odds. The strengths, we use a validated questionnaire. Limitations, poor generalization of the study results. And the recommendations, screening for occupational stress by institutions during pandemics is one of the recommendations from the study. Thank you.
Thank you, Dr. Pradeep. It was an excellent presentation. Presented nicely with the tables and other things mainly. Just I would like to know about the working shifts. Even you said about 30% where they were not able to have the working shift. Mainly, it was related to doctors or the healthcare workers mainly. 30% you said 29.3.
39.3.
Actually, the working shifts actually. So it was not uniform to all the frontline health workers.
Sir, it was it was per day 8 hours of work, sir. It was uniform for all, sir. Even the sisters, doctors, they all worked for 8 hours per day, sir.
According to anxiety was seen more among the consultants or mainly the healthcare workers or the interns actually.
Sir,
so
actually, yes, sir. That I have not presented here, sir. But it was actually seen more in nursing staff, sir. That would take me one more slide. It was actually seen more in the nursing staff, sir.
Because the role of counseling actually, where they would have.
Sir, so what actually the reason was what I felt, the doctors they used to go screen and they come back, but the sisters used to stay there only for whole 8 hours, sir. That was one of the reason which I could make out later, sir.
Thank you.
Okay, thank you, sir.
Dr. Pradeep, good study. Just one clarification I wanted to. You said that,
sir.
if I remember correctly, that those who had already had COVID were not taken into the study, right?
Yes, sir. Yes, sir. Yes, sir.
So out of those who had been taken now, you have any idea any of these later contracted the disease?
Yes,
Do
sir.
you
Yes,
have
sir. Actually, by the time I got IEC clearance from the study, already 95 acquired the disease, sir. Now it's almost 150, sir. So it's almost probably 55 or above have contracted the disease, sir, today. It's almost 4-month-old study, sir.
Okay, okay.
Right.
And now you said that, of course, the screening and all. So other than that screening, any other things that you can think of, any other measures in the light of
Yes,
your
sir.
results,
Yes, sir. There
what
are
would you
various.
suggest?
Yes, sir. There are various studies which tells that stress can be reduced even non-pharmacologically, sir. Something like mindfulness-based intervention. There are few breathing exercises in yoga, cognitive behavior therapy. These are few things which can reduce stress even without drugs. So these can also be addressed, especially when working staff like frontline healthcare workers are suffering from such diseases. And along with that, there are few relaxation exercises also, sir, which can be taught. Diaphragmatic breathing. There are a few list of exercises, sir.
And any other thing like, see, I think you talked about even the working hours and the rest between those working hours and things like that. So do you
Yes, sir.
think that, is there a possibility to do something about that?
Yes, sir. The institutions, it's at the institution level, sir. They can reduce this 8 hours to something like 6 hours. They can reduce the manpower. But when the time when I actually started, sir, we had around 500 cases, almost 300, 350 cases in the ward, sir. So probably even institutions they couldn't do it that time. But institutions should have more manpower so that they can address this schedule, sir, and they can give some break in between also, like at least 1 hour, even when they're working for 6 hours. Because wearing PPE kit, that was one of the difficulty expressed, that like wearing PPE for almost 8 hours itself is a stress for them.
Yeah, thank you. Thank you.
Thank you. Thank you, sir.
Can I invite our last participant, Dr. Chandan, to present?
Yes, I'm here. Can I share the screen?
Yes, sir. I've passed on the control.
Visible?
Just a second, sir. Yes, sir. It's visible. Can I start the timer?
Good evening, participants. I am Dr. Chandan, Assistant Professor, Department of Community Medicine, JSS Medical College. And my title of my study is Awareness and Perception Towards Pandemic Amidst Fake News Among Karnataka, India. Coming to the introduction, pandemic, as we all have taken millions of lives across the globe, and people were suggested to adopt all of preventive measures like frequent hand washing, then using sands, etc. And fake information starting as news and exact to do. So fake information that started spreading across the world, and also lives and promoting like drinking hand sanitizer or drinking alcohol as such, and then preventive they were affected by news at some point of time or the other. Lot of they are not ready to represent.
Sorry to interrupt
So
you, sir.
the study was taken.
Chandan,
Yes. Yes.
Dr. Chandan, your voice is not very clear. Your voice is not very clear. I'll pause the timer. Can you please make sure of your internet connection?
Connection is good and signal is showing.
Sir, now it's audible.
Even
Resume
the
your
slide,
comments.
even the slide was on the first slide. Even the slide for me was still on the title slide. The voice was breaking, and the title slide only was depicted.
Okay, sir. Now is it okay?
Sir, now we are audible. I'll resume.
Now it's fine. Now it's fine.
Okay. Thank you, sir. Thank you.
Restart the.
Okay, thank you.
Yes.
Okay, so with the following objectives, we did this study. The first one is to assess the knowledge, attitude, and practice about COVID-19 among educators of Karnataka, and then to find the association between sociodemographic profile and KP, and then to find association between fake news and KP among educators of Karnataka. And it was a web-based cross-sectional study where we used Google Form, and the study period was for 3 months, that is March to May. And then as the awareness level was not known, so we considered the knowledge to be 50%, and then so by using the single proportion to calculate sample size, we got the 384 as the minimum sample size required, but we got 421 responses and were included in analysis. Then Google Form was developed in 2 languages, that is English and Kannada, and which consisted of demographic details and then questions related to knowledge, attitude, practice, as well as the fake news also. And then we included all the educators who are more than 18 years and those with the gadgets and internet connectivity, which was required to fill the Google Form. Then operational definition of educators we consider as a person who can read and understand either Kannada or English language. Coming to the KP scoring, so for every correct answer we gave 1 score of 1 and 0 for the others, 0 for the wrong answer, and then mean and standard deviation was calculated for KP, and then those participants who had a mean of more than who had the scores more than a mean were considered as good, and less than mean was considered poor. And we analyzed using statistical SPSS version 25. And then AS and attitude practice were expressed as mean and standard deviation. And then questions about KP were expressed in frequency and percentages. Chi-square test was used to find the association. And then P less than 0.05 was considered statistically significant, and IC clearance was obtained before starting the data collection. Coming to the results, majority of the participants, that 58.2% belong to 30 years, 58.4% were females, 61% had completed their graduation, then 30.9% were students, and then 43.5% were either professionals or semi-professionals. And source of information about COVID-19 was television in most of the study participants, that is around 83%, followed by family and friends, which was 72%. And then knowledge about fake news was around the rinsing the nose with saline water. Saline was protects against coronavirus was the opinion of around 23%, and 50% said false, and 27% didn't know. Likewise, for coronavirus transmitted by mosquitoes, 5% said yes. Then eating garlic prevents was one of the major responses given, that is true, by around 42%. And then taking hot bath prevents COVID-19 was around 20%. Then drinking alcohol protects was also answered by around 10%. Then exposing the body to a temperature of more than 25 degrees centigrade was considered to be protective against COVID by around 30% of the study participants. Then coming to the KP scores, the 54.6% had good knowledge, but in spite of that, the 79.8% had good attitude, and 28.1% of the study participants had good practice. Coming to the association between sociodemographic profile and KP, so age, then residential status, education, occupation, all were statistically significant. Followed by only the area of residence, that is urban and rural. It was statistically significantly associated with the attitude as well as practice. So being urban had better knowledge. To the association between fake news and KAP. So all the fake news which we had. Okay, thank you. So all the fake news which I showed in the figure 1 had statistically significant association with knowledge. So people with the study participants with good knowledge had better didn't had these opinions. And then coming to again with respect to attitude, and drinking alcohol protects against COVID-19 was one of the strongly statistically significantly associated with the good knowledge. And then eating garlic helps prevention was also associated with practice. So knowledge is moderate to low in our study participants. In spite of that, attitude and practice scores were good, and there is significant variation with respect to knowledge scores for the age, place of residence, etc. And then so recommendations. So repeated communications and cautions against fake or false news must be communicated through mass media and interpersonal communications. Also, people should be stressed to utilize only authentic sources like WHO and MHFW. Are my references. Sir, am I audible?
Yes, yes, you are.
Okay, thank you, sir. Thank you.
Good study, Dr. Chandan.
Yes, thank you, sir.
Yeah, good study. Now,
Thank you, sir.
I just wanted to know.
Yes, sir.
See, you have said that fake news. I do understand that some of this is fake news, but
Yes,
some
sir.
of these are also the myths kind of prevalent.
Yes, sir. Yes.
Right. So you have labeled all of them as fake news. So that was one of my observation rather than question.
Yes, sir.
And
Yes.
and the other thing is, I don't know. I mean, maybe I missed it. Who were your subjects actually? Who were your participants?
Sir, actually, what we did was we created a Google form and then
Okay.
we circulated it among the people whom we know. That is, it was a convenient sampling. So it
Okay.
was shared in the various groups, and the study participants were asked to share with their known people. So it was
Oh,
something like a snowball sampling which we did.
snowball sampling. Okay. Okay.
Sir.
Right. Yeah.
Thank you, Chandan. It was a nice presentation.
Thank you, sir.
Just I would like to know about some of the myths where they were having about the practices
Yes, sir.
about say wearing the mask or the using the sanitizer. So those things were,
Yes, sir, we had studied all those things, sir, but due to the space, because of the number of slides restricted, so many of the participants, what they opined were that only people with symptoms need to wear mask and the social distancing measures were to be followed by them. And then only self-isolation by those people were what was the opinion of those, whether was the practice of those people. And few people had even attended some gatherings like funerals as well as marriages during that time.
okay. Thank you.
Thank you, sir. Thank you. Thank you very much.
Thank you, Dr. Chandan. We now come to the end of our session. I would like to thank all the participants for their insightful and informative presentation. Also, like to thank our judges for their valuable feedback and guidelines. You are welcome to attend the catch talks and the panel discussions. Thank you.
Also, we would like everybody to leave this meeting because we have another event after this continuing on the same channel. So we'll be adding the other participants.
Thank you.
Yeah.
Thank you.
Thank you
Thank
so
you, sir.
much.
Thank you. Thank you.
Thank you, sir. Thank you. Good evening, everyone. Before I begin the session, I'd like to do a roll call of all the participants of today's session. Dr. Prachit.
Yes, I'm here.
Prachit?
Good evening.
Okay, thank you. Dr. Amrita.
Present.
Dr. Pavitra R. Dr. Pavitra R. Okay. Dr. Chandana Krishna.
Present.
Okay, thank you, ma'am. Dr. Revati. Dr. Revati. That's fine. Dr. Shivraj Somanna. Dr. Chandini. Dr. Lakshmi.
Yes, I am present.
Okay, thank you, ma'am. So we'll start with today's session. Good evening, everyone. Welcome to the 32nd State Level Annual Conference of the Karnataka Association of Community Health, hosted by Ramaya Medical College. The theme for this year is Redefining Public Health, COVID-19 and Beyond. We shall begin with our session, which is the faculty poster presentation. Let us take this opportunity to introduce our judges for today's presentation. Dr. Rajana Sir, Professor Emeritus from Sri Siddhartha Medical College, Tumkur. And Dr. Chitra Nagaraj, Senior Professor, Department of Community Medicine from PES Institute of Medical Sciences, Kuppam. We are thankful for dedicating your precious time to judge this event, ma'am and sir. And moving on to the instructions for today's event.
So the instructions for today's event will be 5 plus 1 minute. That is, you guys will have 5 minutes to present, and at the 4th minute, we will remind you that you have only 1 minute remaining, and then there will be 1 minute for the judges to ask their questions. So let's begin with the first participant, Dr. Prachit.
Just a minute, guys. Could you please give me the control?
Sure. Okay.
Yeah. Am I audible?
Yes, sir, you're audible.
Thank you so much. Good evening, co-delegates. So I'm Dr. Prachit. I'm an associate professor in the Department of Community Medicine, Yenapoya Medical College, Yenapoya deemed to be University, Bangalore. So I'm here to present the findings of my study titled Knowledge Gap of Depression Among Perinatal Women in a Medical College Hospital of Dakshin Kannada, a cross-section study. So as we all know, there is a huge burden of perinatal depression, that is depression in the perinatal women, which ranges from 22 weeks of gestation till 1 year postpartum. And to further compound this issue, we have problems like lack of knowledge and stigma. So in this regard, we conducted this study to assess the knowledge of perinatal depression among women perinatal who are attending medical college. This was carried out for a period of 1 month in February 2019. The sample size was estimated to be 270, based on a previous study carried out in Maharashtra, which reported a knowledge of 19%. The study population were perinatal women who did not have any documentary evidence of mental health illness. The study was carried out in the outpatient department attached to the Department of OBG of the teaching hospital. So we used a validated tool called Perinatal Depression Monitor, which includes 26 items, and for each item there are 3 responses: agree, neutral, and disagree. So this addresses the causes, myths, symptoms, treatment, and prevention with respect to depression. So here we collected the data among the study participants among those who are aware about what mental health illness actually is, so we further interviewed them. And then there was group B who were not aware of what mental health illnesses actually are. So we didn't attempt to interview them further, set a few common questions to the groups. To the findings, out of the 270 participants, 23, that is 8.51%, were in group A. That is, they had some awareness of mental health illness. The mean age among the study participants was 6 years, and around 65% were primary-para. Coming to knowledge about key aspects of perinatal depression among participants who belong to group A. So, 10 out of 23 participants disagreed that depression is a pregnancy. 7 out of 23 participants think that unrealistic expectations led to depression. 8 out of 23 participants opined that depression was not present in past generations, and 10 out of 23 participants disagreed that depression impacted, and 47% of the participants disagreed with the statement that depression is untreatable, and 51% of the participants disagreed that those having depression cannot be cured. So, among the participants in the group A, 34% perceived that all women have to be screened for depression, and this was significantly higher when compared to the second group, and a statistically significant association was found. Coming to strengths and limitations, there are very few studies carried out in India reported on this particular topic, and we also used a validated tool. So our study addresses a very important issue of mental health knowledge gap, which eventually affects both pregnancy and the field. Tool. Coming to limitations, since there were very few women who were aware about perinatal depression, further analysis and assessment became a challenge. So we conclude that there's lack of awareness of about perinatal depression among the study participants. We recommend more campaigns to strengthen awareness among the vulnerable population. We found another similar study carried out in Belgaum, Karnataka, but that was more of perceptions and attitudes towards mental illness among antenatal mothers. We would like to acknowledge Indian Council
Just have 1 minute left.
as a part of a multicentric randomized controlled trial, which is being carried out to assess the effectiveness of a psychological intervention for perinatal depression, and it's carried out in 4 sites. So this was one of the developing that particular interventional study. So thank you all. I'd be happy to take questions.
Thank you, sir. Can we have questions?
We're waiting for Dr. Chitra ma'am to rejoin us. She's facing some technical issues.
Yes, sir.
So Dr. Rajana sir, so you can ask your question, sir.
Dr. Chitra ma'am has just joined.
Dr. Rajana sir, are you here?
Don't call him.
Shall I stop sharing?
So you can stop sharing, sir. We're waiting for our judges to get connected.
Okay. Yeah, sure. Yes.
Okay, Dr. Prachit, due to some technical issues, the judges are not able to connect. Please be waiting. They'll ask you the questions at the end. Meanwhile, we'll go on to our next presenter, Dr. Amruta AM.
Yes, can I share my PPT? Share my screen.
Yes, ma'am. Share your PPT.
Yes. Am I audible?
Yes, ma'am.
Yeah. I'm Dr. Amrita, Assistant Professor in Department of Community Medicine, Basaveshwara Medical College, Chitradurga. I'm here with presenting a poster on knowledge of basic life support among medical and dental students of Basaveshwara Medical College, a comparative study. It's basic life support is a medical process. Sorry.
Your presentation is not yet on screen, ma'am. You've not shared it.
1 second.
Yes, ma'am. It's visible now.
Yeah.
Yes,
The title of the presentation is Knowledge of Basic Life Support Among Medical and Dental Students of Basaveshwara Medical College, a comparative study. We all know that basic life support is a medical procedure and skill which is basically used to save the victim from life-threatening emergency until we reach a medical hospital. We started the study with an objective to explore the level of knowledge about BLS, that is basic life support, among medical and dental students in our college, that is Basaveshwara Medical College. It was a cross-sectional study done among all undergraduate students studying in Dental and Medical College of Basaveshwara. The study was done among 150 medical students and 100 dental students. And, informed consent was taken from all the study participants. We found that the knowledge about safety, that is first response if the person is found unresponsive, was good among medical students when compared to BDS, that is dental. But even medical students lack the knowledge about location for chest compression if CPR is needed, and the depth of chest compression, and the rate of compression in which for adults and children for CPR, that is 100 beats per minute. This knowledge was lacking among medical students and both medical and dental students. We concluded that the lack of awareness among medical and dental basic life support is a serious issue and that needs to be addressed promptly. BLS and other resuscitation skills should be a part of undergraduate curriculum and students should the skills during their studies. We recommend that BLS should be included in medical and dental curriculum.
Thank you, ma'am. Can we have questions?
Hello. Hello.
Yes, ma'am.
Then is there anywhere in the CBME are we including this? Are you aware?
Ma'am, yes. Now have included the BLS training in both foundation course and also in internship. And now they have added Jeevaraksha also, but this study was done well before Jeevaraksha. It was done in 2019.
Okay. What is the best method of teaching them this?
Skills lab, ma'am. How Jeevaraksha is going on now currently? Skills lab. By giving them the scenarios and by giving them the scenarios and then asking them for.
What is Jeevaraksha?
Jeevaraksha is life support management, which is compulsory for internship now, during internship.
Okay, it's called by different names in different states. That's why.
Yeah. Sorry. Yeah, yes.
Okay. Thank you.
Yeah, thank you.
Dr. Rajana, sir, please ask your question.
Can you hear me?
Yes, sir, we can hear you.
Good. My question is, say the MBBS students and then the dental college students.
Yes, sir.
One minute. See, the medical college students, they will have some knowledge.
Yes, sir.
Is there any echo? Shall I?
No, sir. We can hear you.
See, the like should be compared with the like.
Yes, sir.
Like should not be compared with the unlike.
Yes, sir.
Right?
Yes, sir.
So you would have the study group would have been one college students, and then the control group would have been another college students. But
yes,
here,
yes.
compared with the medical college students with the dental college students, it will be like is compared with the unlike.
Yes,
Agree?
sir. Yes, sir. Sir, can I answer? Yes.
Okay,
sir?
then. Okay, thank you.
Hello, sir. Can I answer this? Sir, we want.
You want to answer?
Yes, sir. We wanted to compare medical and dental because both are at the end of the day they both are doctors and they wanted basic life support. So just BLS we wanted to compare. So we compared it with medical and dental.
Is this whatever the information that you have collected? Is it in the syllabus of dental college students?
No, sir. Both the students. It is not in the syllabus of medical and dental.
See, the medical college, they will have some information from the anesthesia department, right?
Yes, sir.
Whereas dental college students, they may not be. I don't
So we
know whether
compared
they will
only
have the
basic
same
life
information.
support, mainly CPR and choking, sir. Basic life support, not the advanced life support, only the basic life support that even a non-medico can do CPR and choking methods. So we wanted at least a minimum knowledge about basic life support.
Okay,
Actually,
see what is ideal is the medical college students and dental college students, they should have orientation by first aid specialist.
Yes,
See,
sir.
somebody first aid, the St. John Ambulance Association, they are giving training on first aid. So there, whatever you are the information that you are collecting, that information is incorporated in the first aid training by St. John Ambulance Association.
Yes, sir.
They are conducting training in some of the medical colleges.
Yes, sir.
Okay. Thank you.
Thank you, teachers. Sir, can we have the Q&A session for the first presenter, Dr. Prachit, now?
Hello. But
Yes.
I didn't even hear him.
Okay,
I
ma'am.
didn't even hear him.
Ma'am, can I ask him to present it again? Can I ask Dr. Prachit to
please,
present?
please.
Yeah, that would be better.
Yes.
Because I can't mark him otherwise.
Yes, ma'am. Dr. Prachit?
Yes. So please, please give me the control now.
Yes.
I'll share my slides.
Yeah, the controls are given.
Yes. Just give me a moment. Yes, I hope you can see my slides now.
Yes,
Yeah,
sir.
it's visible.
Yes. Good evening, respected chairpersons and my dear co-delegates. I hope I'm audible.
Yes, you are.
Yes, thank you. So I am Dr. Prachet. I'm an associate professor in the Department of Community Medicine, Yenapoya Medical College, Mangalore. So I'm here to present the findings of my paper titled Knowledge Gap of Depression Among Perinatal Women in a Medical College Hospital of Dakshin Kannada, a cross-sectional study. So as we all know, there's a huge burden of perinatal depression, and further issues like lack of knowledge and stigma have compounded this particular problem. So we conducted this study to assess the knowledge of depression among perinatal women, that is women in the antenatal group from 22 weeks of gestation till first year postpartum, who are availing antenatal care services in a medical college hospital of Dakshin Kannada. So this was a cross-section study carried out for a period of 1 month in February 2019. The sample size was estimated to be 270. The study population, as I told earlier, were perinatal women who did not have any documentary evidence of a mental health illness. So the study was carried out in the outpatient department attached to the Department of OBG in the teaching hospital. So we used a validated tool called Perinatal Depression Monitor. So it's a 26 item scale, which includes responses ranging from agree, neutral, and disagree. So this addresses the causes, myths, symptoms, treatments, and prevention of depression. So we divided our participants into two groups. Group A was those participants who were aware about mental health illnesses. So we interviewed them further. Whereas Group B were those participants or those women who were unaware about what mental health issues actually are. And so we just asked them 2 or 3 additional questions. So coming to the findings, 23 out of the 270 participants were in Group A. That is, they were aware of mental health illness. The mean age of the study participants was 26.39 years, and most of them, 65%, were primiparous. So 10 out of 23 participants disagreed that depression is a part of normal pregnancy. 7 out of 23 agreed that unrealistic expectations led to depression. 8 out of 23 participants agreed that depression cannot be present in past generations, and 10 out of 23 participants disagreed to the statement that depression implies suicide, and 11 out of 23 participants disagreed that depression is untreatable. 34% of the participants who were in Group A believed that all women have to be screened for depression, and this was significantly higher when compared to those women who were unaware of mental health illnesses. Coming to the strengths and limitations of this study, there are very few studies carried out in India on this particular topic. So this study speaks about a very important issue of mental health knowledge gap, which is very essential for primary prevention of depression among the perinatal group. We also used a validated tool in this particular study. Coming to limitations, as very few women were aware about mental health illnesses, further analysis and assessment became challenging. So the study concludes that there was lack of awareness among the study participants with respect to perinatal depression. We need more public health campaigns and programs to strengthen the awareness of depression among this highly vulnerable population. So coming to references, there was a study carried out in southern India, which looked into perception and attitude towards mental illness among antenatal mothers. And we would like to acknowledge the ICMR who have supported us in this study. So this study was the basis on which we developed an interventional RCT, randomized controlled trial, which is now being carried out in 4 sites across India. So we are thankful to ICMR for the same. Thank you. I'd be happy to take questions. Thank you for giving me an opportunity again.
What kind of intervention have you undertaken?
Yes, ma'am. So we have developed a brief psychological intervention, which includes 3 sessions. That is, the first session is about psychoeducation, wherein we develop insights on the participants with respect to mental health illnesses and depression. The second session, which is carried out 2 weeks after the first session, includes a session on relaxation techniques and exercises. And the third session, which is carried out 2 weeks after the second session, includes health promotional activities like nutrition, rest, sleep, exercise, etc. So we are now testing the effectiveness of this brief psychological intervention. So we have nursing aides who are delivering this intervention at 4 sites across India, and there are JRFs or psychologists who are mentoring them and supervising them and ensuring that this study is being implemented.
No medications are used?
No medications, ma'am. So this is just this depression that this intervention that we have designed is for mild to moderate depression only. So if they have
Outcomes.
Sorry?
What are the outcomes? What are the outcomes you're
Outcomes that
seeing?
we have used for this particular study, we have used PHQ-9. So we are looking at a reduction of PHQ-9 at the end of the interventions. That is 1 month after the interventions. Not just that, they are being followed up further. This cohort that we have are being followed up further through the antenatal period, postnatal, for the fetal as well as infant related outcomes.
Okay. And any problems with families in terms of interpersonal relationships and all, they have a role to play? Or,
Absolutely, ma'am. Absolutely. We have seen that, those having familial marital issues as well as, other problems in the family are being affected more. So this is one observation that we have noted so far in the interim analysis.
Have you put it in the result here?
No, ma'am. This particular paper only focused on the knowledge gap among the participants.
Okay.
We have not put it up in this particular paper.
Okay. Thank you.
Thank you, ma'am.
Hello.
Dr. Rajana, sir?
What is the reaction of the other members of the family towards the mother? The one who is suffering from perinatal depression. What is the reaction?
Yes.
What is the
So
response?
what we have noticed is there is a feeling of denial, sir, first of all, because physical health problems get more prominence as such, and this could be attributed because there's not much of awareness and stigma related to this particular issue. So we have noticed that there is a state of denial among the family members of the participants, wherein they say "Yalla sariyagide," everything is all right. So this is one common observation that we have noted. But however, it will need further analysis. Maybe at the end of the trial, we would be able to accurately conclude what exactly is their reaction, sir.
In your discussion, you said the study conducted in South India about the antenatal depression.
Yes, sir. So this was another.
Any postnatal depression, perinatal depression that
yes,
any study conducted in South India that
so
you have to compare.
Yes, sir. There are many studies that have looked at the prevalence of both antenatal as well as postnatal depression. But with respect to this particular topic, that is wherein we have assessed the knowledge gap. So studies are a little bit scarce as far as South India is concerned.
Okay. Thank you.
Thank you, sir. Thank you. Thank you, chairpersons. Thank you, organizers, for giving me an opportunity.
Thank you, Dr. Prachit, and thank you, judges, for your questions. Although we are having a wonderful interaction, unfortunately, due to time constraint, we'll have to limit our discussions because there's another session scheduled after this. So let's call upon our next presenter, Dr. Pavitra R. Dr. Pavitra R, ma'am, are you here?
Ma'am, are you here?
Ma'am, you're not audible.
Dr. Pavitra, ma'am? Dr. Pavitra, ma'am, we'll check for your audio later. We will continue with the presentation. Our next presenter is Dr. Chandana Krishna.
Hello.
Yes, ma'am.
Good evening, distinguished judges and my fellow participants and organizers. Am I audible?
Yes, ma'am.
Yes.
I'll be presenting a research paper on clinical profile and treatment outcome of COVID-19 patients admitted in a tertiary care hospital in Tumkur. As we all know, coronavirus disease or COVID-19 is an infectious disease caused by newly discovered coronavirus. And it was first seen in the Wuhan city of China in 2019. On 30th January 2020, World Health Organization declared it as public health emergency of international concern. Globally, as on December 2020, there have been 9 crore confirmed cases of COVID-19, including 15.9 lakh deaths reported all over the world by WHO. In India, there have been 59 lakh confirmed cases of COVID-19 with 1.5 lakh deaths. COVID-19 has been showing a wide spectrum of clinical symptoms and signs, ranging from asymptomatic cases to mild cases and even severe cases causing ICU admission and even deaths. So this study was performed to describe the clinical profile and treatment outcome of COVID-19 infected patients admitted at a medical college hospital during this COVID-19 pandemic. So coming to materials and methods, this was a hospital-based descriptive study conducted in Sri Siddhartha Medical College Hospital. This study was conducted between April to December 2020. The study subjects were the COVID-19 positive patients who were admitted in COVID ward and ICUs in our hospital. A pre-tested semi-structured questionnaire was used to collect the data through telephonic interview. Coming to results of my study, the age of the study subjects was 47.5 years with interquartile range of 34 to 60 years, and majority of the study subjects were males and they were from rural areas, and comorbidities like diabetes, hypertension, lung disease, etc. were seen in 36.2% of the study subjects. History of contact with a positive case of COVID was given only in by 16.4% of the study subjects. History of travel was given only by 9.6% of the study subjects. The swab collection center for COVID test was government healthcare facility in majority of the study subjects, and the most commonly used test for confirmation was rat test in majority of the study subjects. Coming to the comorbidities in the study subjects, diabetes and hypertension was the most common one, which was accounting to around 18.6% each, followed by other diseases like ischemic heart disease, thyroid disorder, and even COPD and other lung diseases. Rarely, some cancer patients and anxiety depression were also seen. Coming to symptoms of the study subjects, the most common symptom was fever, followed by cough, and other symptoms included even breathlessness and myalgia. Coming to the treatment outcome of the study subjects, the recovery was seen in 91.9% of the study subjects. The deaths was seen in 5.5% of the study subjects. So to conclude, the present study showed that majority of the study subjects were in the middle age and majority were males from rural background, and the common symptoms was fever, cough, followed by shortness of breath. The mortality was seen in 5.5% and recovery in 91.9%. So this study, since it is a novel disease, such studies regarding clinical presentation and treatment outcome will give some information regarding the natural course of the disease. And I recommend to do some case studies. Hello?
1 minute remaining.
Okay. I recommend to do even widespread community-based studies to get the full picture of what is happening, and also follow-up, post-discharge follow-up studies to look for how is the sequelae and what is the quality of life. So I'm just presenting only the clinical profile and treatment outcome for now. Thank you. Thank you, sir. Thank you.
Hello, Chandana.
Yes, ma'am.
You have put till December, you have recruited patients. Till 10 days are there in December.
Ma'am, many cases have come in the first week of December also, ma'am, when I was taking cases.
Then, now till yesterday you have taken and you have given the data. Is it like this?
I have excluded The total patients was 323. In that, the current cases I have excluded and given treatment outcome only for 307 cases, ma'am.
Then you could have put it would have been till November. If you had taken it, would have been better, no?
Yes, ma'am. Because we got many nursing students. There was sudden outbreak around. I mean, short outbreak kind of almost 25 to 26 patients, and they are still counting. They came from Kerala, and there is again small outbreak kind, ma'am. So I thought of including just for the numbers.
Okay. Okay. Rajana sir can ask. Rajana sir, you can ask.
Can you hear me?
Yes, sir.
This is just an observational study, is it not?
Yes, sir.
Or just is analysis of the case sheet? Is it analysis of the case sheet, or you have interviewed the patients and collected the information?
Actually, the in charge of data management, sir. I have collected each and every patient to telephonic interview, sir.
Personally, you have collected the information?
Telephonic interview from each patient I have collected, sir.
From each patient, you have collected the information?
Yes, sir.
What precautionary measures that you have undertaken?
Sir, through telephonic interview I have conducted, sir. We had telephones in ICU and COVID work for communication with the sisters. So with each patient I have collected information, sir.
Okay. Any information you have collected regarding their knowledge, attitude, and practice? What is the cause for this?
Sir, mainly
What is the cause for COVID? Any information, and what is their attitude? Whether they recover or what are the complications? Any knowledge regarding the complications of COVID? Anything like that you have collected? Because in a good piece of information you collected, further knowledge, attitude, and practice about the COVID would have definitely given more weightage for your study.
Okay, sir. Yeah, correct, sir.
Good.
Thank you.
Next, please.
Yes, sir. Thank you, Dr. Chandana, and thank you, judges. Let's move on to Dr. Pavitra R. Are you here?
Dr. Pavitra, ma'am?
Ma'am, you're still not audible.
Ma'am?
We'll move on to the next participant. Ma'am, Dr. Pavitra, ma'am, can you please try connecting through your phone in the meantime? We'll move on to Dr. Chandini. Ma'am, are you here? Dr. Chandini, ma'am? Ma'am, please unmute yourself.
Yes, sir, I'm here.
We've given you the controls. You can present your poster now.
Okay. Share screen. Share. Am I audible?
Yes, ma'am. Your presentation is also visible, ma'am.
Okay. Thank you. Good evening to the respected moderators and all my co-delegates. I am Dr. Chandni Ashok Kumar, Assistant Professor from the Department of Community Medicine at Akash Medical College, Bangalore. I am presenting here a descriptive study on the self-medication patterns in rural villages of South India. With the background that self-medication is a burning global issue today, especially in developing countries like India, where due to the lack of health services coupled with poverty, ignorance, misbeliefs, and extensive advertisements of drugs, and along with the easy availability of drugs in pharmacies. So WHO actually promotes this practice of self-medication without medical consultations for effective and quick relief of symptoms, and also to reduce the burden on the already understaffed healthcare centers, especially in the inaccessible rural and remote hilly and tribal areas. However, there is a lot of professional concern about this kind of irrational use of drugs, more so because of their adverse reactions and unknown interactions, especially in the vulnerable age groups, that is the extremes of age and stages of life like during pregnancy and lactation, possibly because they could lead to worsening of the already existing disease pathology. So this study was carried out with the objective of determining the prevalence and patterns of self-medication in rural villages. This was a cross-sectional study design which was conducted in the households of villages attached to the RHTC of a medical college. The sample size was calculated based on the prevalence of a previous study as around more than 80%. It came out to be after adding a non-response rate of 10% as 450. 3 out of 10 villages were selected which had similar population size. Households within these 3 villages were selected by systematic random sampling. The tool that we used was a structured pre-tested questionnaire which collected data on the socio-demographic variables, patterns, and attitudes of self-medication. The data was collected by interview method. The informed consent was obtained. The head of the family and or the available persons in the households were interviewed. Data was collected by trained interns under supervision of the investigators. Health education material in local language was distributed at the end. Coming to the results, we found 237 individuals, that is about 51.75% of them practiced self-medication, and table 1 shows the association of socio-demographic variables with self-medication, wherein gender, age, and marital status were found to be significantly associated with the practice of self-medication. When we studied about the patterns and perception of self-medication, we found that more than 62% of them use it only at times when there were similar complaints. They usually got the medications from advice of friends or family, neighbors, media, and about 21% from pharmacies as OTCs. And simple nature of the disease, mild nature, previous good experience of using the same medications, giving good results were the commonest reasons why they practice self-medication. About 87% of them weren't aware of how to store the leftover medicines for future use. And an interesting fact is that more than 77% of them did not have any knowledge regarding the side effects, dose and duration of the drugs that they were using. Table 3 shows the common symptoms for which these self-medications were used, which came out to be myalgia, headache, and abdominal pain. We also assessed the attitude towards self-medication, wherein more than 90% of the study population said that it was harmless to use this practice of self-medication. More than 70% of them said it was acceptable, and more than 90% again admitted that they would like to continue to use it in the future, and more than 50% said that they would like to recommend it to others as well. So strength and limitations, this was a community-based cross-sectional study wherein the patterns and attitudes were assessed. Many studies have assessed the prevalence, but not much about patterns and attitudes. Recall bias could have occurred because of self-reported questionnaire, and only allopathic drugs were considered. These were the limitations of the study. We conclude that a high prevalence of self-medication was reported in this part of the country. Literate adults believing this practice is harmless and time-saving, and they would like to continue to use it in the future and recommend it to others, is an interesting fact which came out in this study. We recommend to create awareness using the simplest measures of mass media regarding the harmful effects and hazards of medications, and regulation of pharmacy and strict law enforcement regarding OTC availability of drugs to bring about good results.
House surgeons in your
Yes.
people who work, and you have put PS Institute of Medical Science.
Yes, ma'am. Yes, ma'am.
How come?
No, ma'am. At that time, I was working there. So when I was working there in PS Institute, that time I had taken, I had conducted the study because I was in charge of RHTC. So there I have involved these house surgeons, and we usually give them one study to conduct, ma'am, so that they'll get a feel of research, and they can be involved in data collection, and they understand how it would be to collect data at the community level, what difficulties they would undergo, apart from their regular OPD work.
Because your PS, you are now in Akash. That's
Akash.
why.
Yes, ma'am. Yes.
What is the connection?
I know, ma'am. It was a little while back. I collected the data. In fact, I even published the study, but I couldn't present it at any conference. So I utilized this opportunity.
When was it done? You have not put period, no? Study period.
Study period was only for about 2 months, ma'am.
No, year of study.
Year when it was done, yes, ma'am. This was a little older one, ma'am, about 3 years back, actually.
3 years back.
Yes, ma'am.
In PS college.
Yes, ma'am.
Yeah, I'm there from 3.5 years.
3.5 years, ma'am.
Must be older.
Yes, ma'am.
I'm there from 17.
Yeah, around, ma'am, more than 3 years, I think. Around 3 years back, that's what I say. If you want the exact date, ma'am, it was around, I think 2000. The data collection was done earlier, ma'am.
That's what I'm asking.
The data collection was done earlier, ma'am. It was somewhere in 2015 that I did the data collection when I was there. Published is around 2017. So 3 years back.
Fine. Okay.
Yes, ma'am.
So,
what are the different drugs that they have taken? Self-medication. What are the different drugs and which you think that it is injurious to their health and known for complications? Side effects.
Actually, in this study, we reported very few of them taking antibiotics, sir. Mostly they were on painkillers. To tell the exact drug, dolo and diclo, because they are given free of cost by the health workers. But few of them were practicing antibiotics, and I think that they, when they were using antibiotics, we were more concerned because they never knew that they had to complete the duration for that. There is a particular dosing, and to take the number of drugs like two times a day, those things they weren't aware. Like they would just take one day and they say, this is okay, I'll just take the medications, because some drugs were available. So those drugs we were more worried about, the antibiotics, rather than other medicines. And of course, gastric medications also, as I told, abdominal pain also. So gastric medication also they were utilizing.
Any comparison? Because this is a discrete study. Just you personally you have interviewed the people?
Personally, we have interviewed, sir, but no comparison. This is a descriptive
Any control group?
No, sir, no control group.
Okay, no problem.
We want to find out what is the practice and prevalence. That's it.
Okay, no problem. Okay.
Okay.
Thank you.
Thank you, sir. I thank all the organizers of KACHCON conference for giving me this opportunity to present my study.
Thank you, Dr. Chandini ma'am, and the judges. Next, we have Dr. Shivraj Nallu Somana, sir. Sir, are you here?
Yes, can you hear me? Yeah. Am I audible?
Yes, sir, you're audible, sir. We're giving you the presenter privileges.
Yes, okay. 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 Chairperson and judges, this study is part of my PhD dissertation. And here I'm going to present the results of the study on quality of life in cervical cancer patients before cancer-directed treatment. So we all know that the cervical cancer in India is most common and leading cause of morbidity and mortality. Definitely, it significantly impacts the quality of life of the patients. And we have seen in the studies that patients have significant problems of social, emotional functioning and reduced sexual or vaginal functioning compared with general population. So we thought that it is assessing quality of life is important and identifying the patient's problem before treatment initiation and addressing them in the health system. So coming to objective, the objective is to determine the quality of life of cervical cancer patients before cancer-directed treatment. So looking at the materials and methods, it was a cross-sectional study on 210 subjects where these subjects were considered who are histologically confirmed cases and who are admitted in a tertiary care center of cancer-directed treatment in Bangalore. So the tool used here was European Organization of Research and Treatment of Cancer questionnaire core model. As QLQ C30 was used, and this tool had 30 questions. And in this study, we had categorized into 3 domains, that is global health status and functional domain, as well as a scale of symptoms. So looking at the collection of the data, so we collected data after obtaining the institutional ethical clearance and written informed consent from the patients, and they were included using a standardized question, which I've said above. So during the period April 2017 to September 2017. So social demographic and clinical staging information was collected from medical records, and other information was collected by the interview. So the statistical methods used here was to describe the data. We used mean and standard deviation. So logistic regression was used to find the independent risk factors for the quality of life. So coming to results, among the 210 cervical cancer patients enrolled, majority, 50.5% of them were between the age group of 46 to 59 years, and 63% were not literate, 71% were financially dependent for livelihood, and almost 50% were in the advanced stage of cancer. So looking at the results, coming to results, we have categorized the score into 3 functional domains. That is, one is a global health status, functional, and scale of symptoms. I have given only few, not all the symptoms are given. Looking at the global health status, that is the quality of life, I have overall quality of life. The scores were 55.2 with standard deviation of 8.3. So here the score was, the minimum score was 0 and the maximum score was 100. So the maximum score says that they have a better quality of life. So looking at the functional, the physical score was 70, average score was 78.6 with a standard deviation of 12.1. And with the emotional, it was 52.6 with a standard deviation of 7. And social had a very low score, that is 51.4 with a standard deviation of 6.8. Conversely, with global health status, in the scale of symptoms, here the scores, the higher the score, so the better the quality. Lower the score, it's a poor quality of life.
So 1 minute remaining.
Okay, in the fatigue score, it was 55.3, pain score was 45.3. And also, if you look at the independent factors which are associated with the quality of life was above 60 years and financially dependent, and advanced stage of cancer was associated with quality of life. So coming to conclusion, definitely the cervical cancer patient had significantly low emotional and social functional health. So advanced stage of cancer and 60 years of above had associated with quality of life. To say the recommendation as assessment of quality of life and intervention should be integral part of management of cervical cancer patients. So these are my reference. So I would like to acknowledge Regional Cancer Institute, Bangalore, Faculty Department of Community Medicine, and as well as Cancer Fund, my guide from Finland, who is from a Cancer Foundation, Finland. Thank you. Would like to take the questions.
You have said you use some QLQ questionnaire. Okay,
Yes.
which language was that in?
But I didn't get you, ma'am.
You said you've used that questionnaire, no?
Yes.
Questionnaire
QLQ 330.
It was in which language it was printed?
It was in English.
English. Then, like you got it translated to local language and used, or you used it?
It was even in Kannada version also it is available. They have converted for almost most of the languages. I use the Kannada version also, Kannada version as well as English version.
Okay, okay, thank you. So
So, Dr. Rajana, sir, so please ask your questions.
What is the duration of study?
6 months, April 2017 to September 2017.
Which hospital in Bangalore?
I don't know whether I have to, because they have said that not to.
Because is it a specialty hospital?
It's a tertiary care center in Bangalore. I think you understand. It's a tertiary care center in the Bangalore, population-based cancer center.
And early diagnosis, you have mentioned importance of early diagnosis
of quality of life.
Quality of life.
Yes.
So what is the
normally it is not being seen. Only they look at the treatment aspects only. So there is a lot of quality of life problems like emotional and functional problems, physical problems. So we have to address even that also and integrate in the management of the treatment. This is what I'm trying to recommend.
Now, any specific information you have collected specific to cervical cancer, for example, genital hygiene, something like that.
So this is a part of my main study. The main study was different. This was a small part of that study.
Okay. Okay. Thank you.
Thank you.
Thank you, and the judges for the wonderful question. Can we move on to the next presenter, Vijay Lakshmi ma'am?
Yes. Hello. I'm present.
Yes, ma'am.
This is, hello. This name is not there in the list. No new person, is it?
No, ma'am. This is presenter, ma'am. Dr. Vijay Lakshmi.
Vijay Lakshmi.
There are only 7 names here. Vijay Lakshmi's name is not there.
Ma'am, it's there in the last.
Ma'am, it's the last one, ma'am.
I have only last Prachet, Amruta, Pavitra, Chandana, Revati, Shivraj, and Chandani. That's all in my list.
No, ma'am, this is the last. Yes, ma'am. Okay, I'll send the details again. Okay, ma'am. Ma'am, this is Dr. Vijay Lakshmi Mangasuli, ma'am. Her registration ID is RMCK.
No, that's okay. I will just write the name. Doesn't matter.
Okay.
Good evening. I'm Dr. Vijay Lakshmi, Assistant Professor in Department of Community Medicine, Basaveshwara Medical College, Chitradurga. I am presenting my study on Tethering Adolescence and Parenthood, a study on parent-adolescent interaction. The quality and the nature of the care that we give to a child and which is received in the adolescent phase is an impact on their development both mentally and physically. So this study aims to quantify the bond between the parent and adolescent. So we did this study with the objective to study the parent-adolescent interaction, to assess their dietary pattern and also to assess the academic performance of the school-going students. We did the study among 200 students with the help of a pre-designed self-administered questionnaire consisting of 2 parts. The first part with a socio-demographic profile and the second is we have used a questionnaire, parent-adolescent interaction assessment questionnaire having 33 questions. We have conducted this study from 9th to 11th grade among 2 schools of Chitradurga district. Coming to the results, majority of the students surveyed are the males, that is 53%, belonging to the age group of 14 to 15 years, studying in the 10th standard, coming from the urban background. And the most of the students' parents are married and one of the parents are working distantly. The father, when we studied their, we have studied the father's education, mother's education, father's qualification, mother's qualification, and also their interaction and time spent on with the students and time spent with the homework. First, coming to the student satisfaction with the time spent by their parents, we have asked about the time spent with the parents, both during homework and others also. And we have asked regarding the satisfaction. Majority of the students are satisfied with the time spent with the parents. 62, that is 31% of the students who are satisfied, they spend time with their parents of 5 to 6 hours. And the difference is significant. And when we studied the academic performance, we have studied the academic performance compared to the high school as 3 grades, better than primary school, poorer than the primary school, and no difference between the primary school. And we have studied the association of their performance with respect to father's education, mother's education, parents' relation, background, time spent on the homework and help received by the parents. And we have seen that the students who have a better performance with the better education, as we know, and also the parents' relation. And we have found a significant association with the help received by their parents in the, especially in homework. And regarding dietary pattern of the study participants, majority they have the home cooked food in the school and they spend time with the family. And few of the students also skip the meals. To conclude, maximum number of the students are satisfied with the amount of the time spent with the parents, and the students who received help with their studies have a better academic performance, and most of the students have the home cooked food. So parents should be aware about the mental health of their growing adolescent. They should help their children to cope with the stress of academics and have meals together as much as they possibly can. These are my references.
Regarding your objectives, to study, is the word study an appropriate objective which you have used?
To assess the parent-adolescent interaction.
Because somewhere it is very vague. It's very, very vague.
Okay.
And what using assess their dietary pattern, what information did you get using that dietary pattern? What are you trying to say? If they have dinner with family, good or bad?
If they spend, we have not assessed their nutrition status, ma'am. We have asked regarding whether they, is it helping to, for interaction, is it helping? If they spend time with the family for dinner?
Then it is not dietary pattern, no. It is dinner with family or without family, no?
With family.
Okay, it's okay. Next, sir can ask. Rajana sir, you can.
This conclusion, parents should be aware about the mental health of their growing adolescent. Mental health is a very big topic, is it not? Hello? How you were able to come to the conclusion that the very important conclusion, second part of the second para in the conclusion is parents should be aware about the mental health of the growing adolescent.
Sir, actually,
So what is the information that you have collected regarding assess their mental health?
Sir, actually, that is next step. Assessing the interaction, we can make next step go ahead with the mental state. That is to recommend the next step after this study.
Not audible.
Sir, is it audible, sir?
Now you are audible.
After concluding their satisfaction, the next step.
Again, you are not audible. Please,
Hello?
please use the mic or something. Hello?
Is it audible?
Now you are audible.
So this is the next step. After assessing their interaction, to go ahead with the mental health. That is the next step of conclusion, recommendation. That is not the conclusion of my study.
No, you have to mention the conclusion of your study.
Yes, sir.
But here you have mentioned as though it is your conclusion.
No, sir. It's not my conclusions.
Okay. Thank you.
Thank you.
Thank you, Dr. Vijayalakshmi ma'am, and thank you, judges. We have the last participant meeting, Dr. Pavitra R. Ma'am, are you here?
Am I audible now?
Yes, ma'am.
ಅದು ಹಂಗೆ ಲಾಗಿನ್
Present the privileges.
Yes.
Ma'am, do you want to present the privileges on your phone or on your laptop, ma'am?
On my laptop.
Yes, ma'am. Given your laptop.
ಏನೋ ಪ್ರಾಬ್ಲಮ್ ಆಗೈತೆ ಸಾಕಾಯ್ತು ನಾನು ಇದು ನಾನು
Dr. Pavitra ma'am.
Yes, can I share my PPT?
Yes, ma'am. Ma'am, please share your PPT, ma'am. Ma'am, we've given you the sharing privileges for your laptop.
Yes, is it visible?
Yes, ma'am. No, actually, it's blank.
Ma'am, it's blank. It's completely black, ma'am. But there is some screen that is being shared.
Is it visible now?
No, ma'am, it's a blank screen. Yeah, now it is. Can you put it on slideshow, ma'am?
Yes. Is it okay?
No, ma'am, it's blank again.
Ma'am, it's blank again,
Is it
ma'am.
visible now?
No, ma'am. Yes, ma'am. Now it's
Now it's
visible.
okay.
It's visible, ma'am.
Yes.
Okay. I'm assistant professor from Medical College, Chitradurga. So my study on occupational stress among bank employees in Belgavi city. So recent decades we have witnessed tremendous advancements in health and survival throughout the world. So with economic transition, there is the working pattern and lifestyle among the workforce has changed. So it has been seen that in a study, the banking sector is among the top 10 high stress workplaces. So due to these, employees are experiencing high level of stress. So though medical benefits are provided to this sector, there are no health promotion and preventive measures taken towards the occupational conditions, and therefore this group of population has been selected. So the objective is to assess the occupational stress affecting the health of bank employees. It is a cross-sectional study. So based on the prevalence of the stress in the other study, the sample size was taken to be 290, around 290. So overall, the list of the nationalized banks was listed, around 182 banks, and around 30 banks were selected, considering 6 to 8 employees in a bank. And then the banks was selected through simple random technique. So using the occupational stress index, they were divided into normal, severe stress, and distress. So around so 15.5% of them were normal. So around 69% were found to be in distress, and 16.5 and 69% in distress and 16.5% in severe stress. So coming to the assessment of factors associated with stress levels, so the age factors and the other socioeconomic conditions were not much significant, but the only one that was significant was among diabetics. There were 48.8% diabetics who were distressed and 24.4% who had severe stress. So coming to the conclusion, most of the bank employees were having multiple risk factors, lifestyle and work-related risk factors. More than 3/4 of bank employees were distressed at workplace, and 1/5 of them were under severe stress. So we would recommend regular personal management techniques for the bank employees to tackle the stress at the regional level, and these are my references. Thank you.
You didn't, Pavitra, you could tell something about the tool you used. You never said anything to.
It is basically I've used occupational stress index scale, ma'am. So it was taken from the reference from the other similar study. And
Which
it was
similar
the
study?
Some
Some other. Okay, reference.
Employees reference, the third reference.
Okay. Is it a standard scale?
reliability and validity were checked, and it is a standard.
How could you make your study better?
Might be associating stress levels with other conditions.
Okay, but to benefit the people whom you did the study on, what could you do to improve that?
Ma'am, basic personal stress management techniques could have been given to them.
Intervention. You could make it a interventional study, no? Then the
Yes, ma'am.
weightage of the study will be better than just doing a cross-sectional study and leaving it like that. Okay.
Yes,
Rajana sir. Rajana sir, you can ask.
This is a descriptive study of the bank employees. Hello?
Yes, sir.
Any comparative study? Any comparative? Can you hear me? Can you hear me?
Yes, sir, you're audible.
See, the only whether it is a bank employees or a government bank or private bank.
Both the banks were taken, sir, but as you said, for comparing, I could have compared it to the managerial position and other group 4 employees, but employees were not included in the study.
Any table comparing the the stress level is more in the private bank compared to government bank, something like that?
No, sir, that was not been compared. Overall, the banks were taken, sir.
No. See, you said the employees are both from the government bank and private bank.
Yes.
Right?
Yes.
What percentage from government bank and then what percentage from the private bank?
Okay, that was not being done, sir. That was not compared. The banks were they were not compared.
You said the employees, the study subjects you said are both from the government bank and private bank, right?
Yes, sir.
I cannot hear you.
Yes, I can hear you.
So what percentage from the government bank and then what percentage from the private bank? Because my hypothesis, I may be wrong. The stress level is more in the private bank employees because more and more pressure compared to government bank. Ayo nadiyutte chalta hai.
Okay.
Anything like that you have analyzed?
So not analyzed, but it will be taken forth, sir. During interventional study, I think I can compare it and then intervene.
Okay. Okay.
Yes. Thank you.
Thank you, Dr. Pavitra ma'am. We are done with all the presenters for the day. We tried reaching Dr. Revati ma'am, who was supposed to present, but we couldn't reach her. So these all are going to be the presentations for the day.
Coming to an end of the session, we'd like to thank all the presenters for their insightful and enlightening session. And we'd also like to thank the judges, Dr. Rajana sir and Dr. Chitra ma'am, for their valuable time, their guidance and their feedback. Thank you very much, ma'am and sir.
Whatever the marks that we grade or marks that we give, I may take little time. Is it okay?
Sure, sir.
Okay. Thank you. Thank you very much.
Thank you, sir.
Thank you.
You all.
Yes, sir.
I just said thank you all. Thank you all. It was wonderful.
Thank
Well
you, sir.
conducted by the host. Thank you.
Thank you, everybody. Thank you very much.
Thanks, sir.